Another procedure that we do for chronic mallet fingers. Now this is a procedure that is more commonly done when they have a swan neck deformity. So those patients that have some ligament laxity, where their PIP joint will go into a hyperextended position without an injury, and then they develop a chronic mallet, those patients will actually develop a full swan neck configuration to their finger. And in those patients, if they don't respond to splinting, then a spiral oblique retinacular ligament reconstruction is the preferred method to treat those conditions, because it addresses both the hyperextension at the PIP joint as well as the lag at the DIP joint. So here we have, again, so SRL here is the procedure, stands for spiral oblique retinacular ligament reconstruction. Another name is the Thompson procedure. He's another physician that has described a certain technique, so you might hear both of those. And what we do is we basically try to reconstruct the normal anatomy of the finger, this oblique retinacular ligament, which is a normal structure in the finger. In most people, not everyone has it. And it allows the smooth, coordinated extension of the finger. When you extend the finger, the PIP and the DIP actually work in concert. And this ligament is one of the reasons that happens through this type of tenodesis effect. And so those patients that have an incompetent terminal tendon and a hyperextension deformity at the PIP joint, we can use a palmaris longus tendon graft. So if you look at the wrist, touch the thumb and the pinky, this is the palmaris longus tendon right here. We call it spare parts as hand surgeons because we can use it without causing any long-term problems and use it for reconstruction in various cases. And so you use that as a graft, and you essentially reconstruct this ligament here. The graft oftentimes is sewn into the A2 pulley here. So you'll have the A2 pulley, just like that. And so the graft, you'll sew it into the fibroosseous sheath of the A2 pulley. It has to pass palmar to the axis of rotation of the PIP joint, all right, to counteract the hyperextension deformity of that joint. And then you pass it up dorsal to the axis of rotation at the DIP joint, and then sew it into the distal phalanx. And oftentimes we'll use a little suture anchor, drill a little suture anchor into the bone that has suture in it, and pass that suture through the graft to hold it there. And so that provides an extension force at the DIP joint and a flexion force at the PIP joint to counteract both those deforming forces.